Um, Hello, friends. This is Arvind Singh here from Essex Cardiothoracic Center. First of all, thanks for the invitation to present in this teaching course. And also thanks to the resilience of both the societies and Prof. Amar, who had conducted such a fantastic couple of training days a couple of years ago. And we really missed it last year. And I'm glad that in some format, we are able to do this, although seems quite strange because you're not talking to an audience, you're sitting in a room and looking at your laptop or a computer and trying to think that some kind of interaction is going on. So the remit given to me today is on aortic surgery. It's also a field of my interest. One of the important things which I always felt about aorta was that whenever we thought of aorta, we thought of parts of aorta. But more and more I started operating on patients with aortic problems. I realized that you have to look at the whole aorta and not just the part of the aorta that you happen to see in the pericardium or the arch. Which is what most of the cardiac surgeons will come across. And more often, more important than that, I thought was think of aorta as an organ. Think of aorta as an organ which starts from the heart, traverses the mediastinum in a curvilinear fashion, going up first and then forming an arch and then going behind into the posterior mediastinum. So the areas that it actually traverses is significant, and therefore, we have to think of aorta in its entirety, because any intervention on the aorta on any segment, especially anything beyond the ascending aorta, is going to create various technical as well as physiological challenges which one has to deal as a surgeon, and therefore think of aorta as an organ. Think of its extent, as I said, it's going from the heart, going up, ascending arch, and along the spine into another cavity then, which is abdomen, and then dividing and going into the lungs. And obviously, what's its natural purpose? Its natural purpose is to supply blood to everything in our body. So that's how I start describing it to my patient. Look, your aorta has a problem, and aorta is a structure that provides blood to the whole of the body. And think of the location where you need to intervene. And obviously, the moment you start thinking of aorta in these terms, you then start thinking of the area of the aorta that I'm going to deal with and what comes next to it. What is it really in close relation to, and how is the function of that particular part of the body going to be affected by what I'm going to do to the aorta. So obviously, whenever you think of ascending aorta, you're going to think of the left ventricular outflow tract, you're going to think of the aortic root, you're going to think of the aortic valve. And obviously, you're going to think of the coronary arteries, because they are just going to take the origin just above the aortic valve. Following that, arch of the aorta with all the cranial vessels and upper limb circulation. And interestingly, the upper limb circulation comes very handy for a number of aortic surgeons, depending on what strategy they want to use to deal with the various segments of the aorta. And then the descending thoracic aorta, the hallmark as far as surgeon is concerned, thing that one has to worry about or think about in our management, surgical management, is the spinal blood supply. And finally, the abdominal aorta. I know most of us will not be involved in dealing with the abdominal aorta as cardiothoracic surgeons. However, most aortic surgeons work very, very closely with vascular surgeons, and certainly I do. When we are dealing with problems of the aorta, it's us together. Also, one has to remember that the vascular surgeons have made leaps and bounds of progress with the advent of TEVAR, and allowed us to perform interventions on the descending thoracic aorta with much less morbidity. And therefore, it is quite imperative that a good collaboration develops between us. So this is the usual anatomical picture that you tend to think of when you think of the aorta, and pretty much the description that I have just mentioned. Pathologies that we will be dealing with in terms of the aortic problems are concerned, these are the structural problems that you see. So aneurysm, obviously dilatation, aortic dissection, intramural hematoma, and penetrating ulcer can all cause acute aortic syndromes. And some of these can present, of course, in a chronic fashion. And they usually are because of these things. So atherosclerotic problems with the aorta being the commonest. However, any aortic surgeon who deals with a fair amount of aortic pathologies will certainly come across Marfan's. Ehlers-Danlos, Loeys-Dietz, a bit less common as compared to the other pathologies. And the inflammatory pathologies, again, extremely rare, but again, one would come across these having affected the aorta, which actually led to an operation. I think the other commonest pathology that we come across a number of times as cardiac surgeons is a bicuspid aortic valve. For either stenosis or regurgitation, you end up operating on patients with bicuspid aortic valve and then have to deal with the concomitant aortopathy. Infective mycotic aneurysms are not that common, but one can still come across them, and of course traumatic. If somebody survives a trauma and then leads to weakness in the aortic wall, or in acute settings where they come in extremis, if they at all reach cardiac theaters. So presentation, most often the symptoms are from the mass effect, could be pain, hoarseness of voice because of compression on the recurrent laryngeal nerve, and sometimes, although not very common, is difficulty in swallowing if they have a compressive effect on the esophagus. The other reason why these patients do present to a doctor are not related to the aorta at all. They are because of aortic regurgitation, because of dysfunction of the aortic valve. The cause can be an aneurysm of the aorta and distortion of the aortic root, dilatation of the aortic annulus leading to aortic regurgitation. But per se, the symptom is actually arising from dysfunction of the aortic valve. Embolism can occur from the mural thrombi, which are present and lining the large aneurysms, or it could be atheroembolisms. In a normal setting, when you receive a referral for aortic problems, like anything else, could be elective referral or acute referral. Elective referrals most often are patients who were investigated for chest pain or shortness of breath. And the fair or the biggest share, as I say at the bottom of my slide, actually come from incidental findings for some other diagnosis. And certainly using imaging modalities like CT and MRI for several other things in the body, and in general, the use of these two imaging techniques has now increased the number of asymptomatic aneurysmal dilatations that we have started to find. Many of these will find the route into a surveillance program, but quite a few of them are asymptomatic, but they have reached the threshold. So purpose of the investigations is going to be to do a diagnosis, to understand the anatomy, to understand what the aneurysm is doing to, or aortic pathology is doing to the neighboring structures, essentially plan the operation, and then look for and investigate the associated conditions. From our point of view, primarily look at heart, and of course, the rest of the investigations for fitness. So these are the usual sets of investigations which all of us are quite aware of. The one added investigation, if somebody wants to be really feel reassured about while performing operations on aortic arch, is to understand the anatomy of the circle of Willis. Although I have heard a number of experts speak at international conferences where they have said, there is always a communication between the right and the left side. However, if a surgeon wants to feel reassured, I don't see any contraindication in performing this investigation and making sure that there is a continuity and there is a good circle of Willis communicating between all the feeder vessels to the brain. So I'll jump to guidelines because it's a huge topic to be covered in 30 minutes. Some of the important guidelines. One important thing that I would always say about imaging of the aorta is, especially for the surveillance programs, is that it should be done by a aortovascular radiologist. Because one thing that's important is that it should be consistently done at a specific point or a specific landmark in that particular patient, so that if there are any serial changes, then they are documented properly. At the moment, I have a list of almost 10 patients where I am going to go back to my aortovascular radiologist because it's been reported by different people at different, different stages. And actually some of the aneurysms have decreased in size, which, it's not possible. At least they should remain the same size, if not increase in size. So that's the importance of performing axial measurements perpendicular so that we get an exact diameter of the vessel at that place. Again, as far as diagnosis in acute situations is concerned, gated CT becomes extremely important so that the motion artifact of the ascending aorta does not happen, so that the aortic dissection flap can be seen clearly. So these are the things that I already mentioned just now. Coming straight to ascending aorta, which is the segment of the aorta we will be dealing with most often as cardiac surgeons. There have been several meetings and several MDTs where I found that there has been significant confusion around, bicuspid aortic valve and what's going to be the threshold size to do something about it. And it's quite clear when you are operating on a bicuspid aortic valve for aortic stenosis or regurgitation, anything more than 45 is going to be, so 45 millimeters is going to be your threshold. The problem arises when bicuspid aortic valve patients do not have a significant aortic stenosis or regurgitation. Their bicuspid valve is functioning fine. And the guidelines still say that if they are non-syndromic, if they are not high-risk bicuspid aortic valve, and high-risk bicuspid aortic valve have been defined, I'll show you in the next slide, then the threshold still remains 55. If they are high-risk bicuspid aortic valve, if there are risk factors in the bicuspid aortic valve, then the threshold goes down to 50 millimeters. As far as Marfan's is concerned, again, non-syndromic, 50 millimeters, and Marfan's with risk factors is 45 millimeters. So this is what I meant when I said about the bicuspid aortic valve. If there's a family history of aortic dissection, if there are connective tissue disorders associated with bicuspid valve, and hypertension have been included in labeling the bicuspid aortic valve as high risk. The same indications and the same thresholds have been now reconfirmed in the bicuspid aortic valve AHA guidelines, which have just come out a few weeks ago. Essentially, the thresholds are same as mentioned in the European guidelines. So to sum it all up, a degenerative atherosclerosis 5.5, bicuspid aortic valve 5.5, bicuspid aortic valve with high risk factors 5, bicuspid valve requiring AVR 4.5, Marfan's is 5, Marfan's with risk factors 4.5, Loeys Dietz it goes down to 4, and familial syndromes with gene mutations goes down to 4.5. Every guideline also mentions that one can have a look at the patient size and therefore thereafter alter the threshold if you're looking at a small patient. I think at some point we will have to, as a society, graduate to using the body surface area or height of the patient, something that takes into account the size of the patient, because currently all the thresholds are same for somebody who is 6.5, 6 feet 5, or someone or the other person who is 5.2. So I think it's important that all these things need to be reflected in the guideline in some scientific way rather than completely subjective. Descending thoracic aorta, I think in the current era where TVAR technology has improved so quite significantly, that is a class 2A indication at this moment in time for dealing with descending thoracic aortic problems. Unless TVAR is not possible, the patient can be subjected to surgery. TVAR has been used for almost everything that now affects the descending thoracic aorta, be it type B dissections or contained rupture, penetrating ulcer, intramural hematoma, as long as we got a landing zone. And sometimes we as surgeons need to provide them a landing zone. We should be able to manage most of the descending thoracic aortic pathologies with TVAR. Aortic dissection, we all know type 1 aortic dissection has to be treated with emergency surgery. What is changing gradually is the management of type B aortic dissection, whereas hallmark of the type B dissection management still remains control of blood pressure. I am expecting that in next few years, we will have some specific guideline as to which of the type B aortic dissections should be intervened sooner than later. In our unit, we work very closely with the vascular surgeons, and we started doing serial CT scans before sending the patient home, just to make sure that that type B dissection is not increasing in size. And ongoing chest pain, although there is not much of a change in the size, is again something that we started worrying about. And appearance of pleural effusions along the aorta is again something that we started thinking of as a low threshold for intervening earlier rather than later. Intramural hematoma. There was a time when intramural hematoma was always a debate. I still remember about 10 years ago when I was a registrar, we had a patient with intramural hematoma, and there was no dissection flap. A number of investigations were performed, and finally very aggressive blood pressure management was done, and that one patient didn't require an operation. This patient had an intramural hematoma which was affecting the ascending aorta, and therefore using the same argument for the next patient, where we sat on that patient who then 3 days later developed free flap and a proper type A aortic dissection, for which we then had to subject the patient to an emergency surgery. So now the guidelines are quite clear. Treatment of intramural hematoma literally follows the treatment of aortic dissection, type A to be operated upon, and type B to be treated medically, which is what this guideline, the European guidelines now reflect. Penetrating ulcer, hallmark of penetrating ulcer treatment is medical therapy and adequate blood pressure control. Again, they have been intervened sooner than later due to the other factors that I mentioned to you in type B dissection, as well as if it's type A and if the anatomy looks as if this ulcer is about to rupture, then one would subject these patients to an operation. Contained rupture of thoracic aorta. Again, this is something that we talked about earlier. Treatment would be with TUR. And traumatic injury, the treatment would depend on the location as well as the acute or chronic nature of the aortic involvement. There's some guidelines which appear in the European Society of Cardiology as recommended surgical techniques, and these guidelines are not telling us about just one aspect, but they are touching on several aspects. So the first one mentioned here is cerebral CSF drainage. So if a significant segment of the thoracoabdominal aorta is going to be affected by the surgical procedure or by the TUR, CSF drainage is indicated. It's a separate topic in its own, and I wouldn't want to go into the details of that for now. The second mention here is aortic valve repair using reimplantation technique or remodeling is recommended in young patients, especially if their aortic valves are tricuspid. So again, the leaning now is more towards trying to preserve the valve, trying to repair the valve, and the third recommendation is open distal anastomosis for a type A aortic dissection repair. So invariably, this means every type A aortic dissection repair has to have circulatory arrest. And that is something one has to be prepared for in these patients. The other recommendation being selective antegrade cerebral perfusion. The level of evidence is B, and recommendation is 2A. As I mentioned earlier, the arch of the aorta gives rise to the three branches supplying the arm, the upper limbs, and the brain. And it's the upper limb arteries which have now become quite regularly the site of cannulation as far as the cardiopulmonary bypass is concerned. And obviously that helps us to give antegrade cerebral perfusion to the brain during the circulatory arrest. And there's a mention of using left heart bypass whenever you're using, whenever you're operating on the descending thoracic aorta. Just a quick mention before we go on to the operations, a quick mention about risk scores and to understand that any aortic intervention actually increases the risk. And the issues beyond the usual are bleeding, stroke, and paraplegia. And these are the things that you would want to prevent in every patient, but in these patients, one has to be, probably has to have a strategy to prevent cerebral ischemia, to prevent spinal cord ischemia, and obviously to control the bleeding at the end. And this is just a snapshot of what risk score does. This is from my phone. This is from my phone app, which I normally use when I'm looking at a patient and calculating their risk and explaining to them about Euroscore. And I've just used a simple template, 78-year-old man who has no comorbidities, normal left ventricular function. And I've used a single non-CABG as a procedure. and an elective 2 procedures with operation of thoracic aorta. And you can see that the Euro score from 0.84 goes to 2.72. Almost all of our patients, or a number of our patients at that age, will have some form of comorbidity or the other. And the other thing that I haven't scored here is if they're going for a single non-CABG, they will have some symptoms as against purely an aortic operation. Nevertheless, what I mean to show you here or demonstrate here is when you operate on thoracic aorta, the risk does go up quite significantly, and therefore the challenges of aortic operation and challenges of operating on aorta must be acknowledged, and there has to be an extensive planning, especially if you are operating on anything beyond the ascending aorta. Therefore, the approach, excellent communication with the perfusion team as to what cannulation strategy you're going to use, how you're going to protect the myocardium, because while you have finished everything in the aortic root, and then going towards the aortic arch, the heart still needs to be protected, and the protection could be either cold blood cardioplegia, warm blood cardioplegia, depending on whatever you do routinely, or the third possibility of using continuous perfusion, warm perfusion of the heart while you're doing everything else at the arch, so that the heart continues to beat and the ischemia time is reduced significantly. Similarly, a good plan for cerebral protection and spinal cord protection is essential. Unless we look at all these factors, we'll not be able to plan an aortic operation properly. This is just another way of looking at how you're going to operate, and these are the way we have defined the zones, so that when you're thinking or planning an operation, we all speak the same language, and we know exactly at what location we're going to do the stitching and the surgical procedure. I did mention to you earlier about good collaboration between the cardiac and the vascular surgeons. And we in Essex Cardiothoracic Center, when I came here, I found that we did not have a good collaboration amongst the team dealing with the aortic surgery. And we then formed a good aortic MDT to come on a single platform and make plans for the patients. And in Essex, we have 5 district general hospitals. We have developed telelink with 1 and 3 hospitals have already come together, and we are collaborating quite nicely at this moment in time. We have developed an aortic MDT, simple referral form, and since November 2016, extensive discussions. The number here is wrong. We have discussed now more than 400 patients in these many years. And that has increased our number of new patients coming in with aortic pathology significantly. We want to develop on-call services for type B and type A aortic dissection, and we're still in the process. It's bringing so many hospitals together is not easy, but we hope to come to some fruition in next few months. We also have a hybrid theater in our unit, and we have therefore been able to deal with some interesting patients. So here's a 75-year-old female who had ascending aortic aneurysm and type B aortic dissection. She actually presented with type B aortic dissection. We controlled her blood pressure, managed her medically. However, there was almost 6.5 centimeter ascending aortic aneurysm. And therefore, in the same admission, we first performed an elephant trunk procedure, following which my vascular surgical colleague performed TEVAR with very successful outcome. This is a year later, and the lady is doing quite well, still seen in the outpatient clinic. This was again an important finding, in the sense the gentleman had a type A aortic dissection repair long ago, was lost to follow-up, came for some problems in the chest, for which a respiratory physician asked for a CT scan and found to have a almost 8 centimeter type B aortic dissection, which my vascular surgical colleague stented quite nicely, as you can see here, and that's the outcome. The type B dissection has shrunken quite significantly after that. Some patients where we collaborated in the hybrid theater, patient needed 2 bypass grafts and had a large saccular aneurysm just distal to the left subclavian. And as you can see here, following the bypass grafts, I then performed the debranching with another graft coming from the ascending aorta, so that my vascular surgical colleague could then stent, could have a landing zone for stenting. We did that in one sitting, which is I think always good, because we have sometimes lost patients while they were trying to recover from one operation to go for the second one. And this CT scan will demonstrate the success of this approach. As you can see, the debranching vessels can be seen just next to the ascending aorta, and the TUR has completely isolated the saccular aneurysm. I think I do have quite a few slides, but I know that I have reached my time limit. I'll just show this one, 81-year-old female, very fit otherwise, no comorbidities at all. I had a 6.3 centimeter aortic aneurysm just distal to left subclavian. Her coronaries were normal, valves were normal, so we actually performed an off-pump debranching by just reducing the blood pressure to about 60s, 70s to be able to put a side biting clamp on the ascending aorta, and then perform the debranching of all the 3 vessels. The left subclavian was deep inside the chest, so we took another graft from the left axillary coming through the intercostal space, and then joined it to the 3rd branch of our debranching, which then allowed my colleague to insert this TUR. You can see the retractor at the top, which is where we approach the left axillary artery. So quite clearly, that's the post-op CT. You can see the large aneurysm, 8 centimeter aneurysm, completely isolated. And again, this lady is doing quite well. I would stop for keeping the time, and I hope I have been able to touch on various aspects of thoracic aortic surgery. Each one of these could be then explained into minute details, and we can have separate sessions for them. But thank you for listening to me, and thank you for the opportunity at such a wonderful forum.